My name is Sarah, and I am a clinical dietitian at the Prince Charles Hospital and a PhD candidate at the University of Queensland in Australia. Firstly, we need to clarify something that can sometimes be confused or interpreted differently in different places. To keep things simple, in this unit we will define three stages of nutrition risk status. The first is well-nourished. People who are classified as well-nourished should not be at risk of becoming malnourished, or they do not already have malnutrition. So they should be eating and drinking enough for their needs and have adequate muscle and fat stores. At risk of malnutrition. This is the second category, and it is sometimes referred to as at nutrition risk or simply at risk. This category can represent two groups of people: those who are not yet malnourished, but who are not receiving enough nutrition for their needs. It can also refer to those people who receive a positive nutrition screen, who have not yet received a thorough nutrition assessment to check their intake, nutrition requirements, and a physical assessment of their muscle and fat stores. Remember that people do not have to be thin to be at risk of malnutrition. The third category is malnutrition. A diagnosis of malnutrition should be reserved for those who have been assessed as malnourished using a validated tool. Validated tools always check for nutrition intake adequacy and include a physical assessment. They don't rely on just one measure like a BMI or blood markers. And in fact, we know that many people who are malnourished may be overweight, living with obesity, or have normal blood markers. So who should be offered information about nutrition risk status? First, anyone with a recent hip fracture should be considered at risk of malnutrition and offered information about this. Even if they seem okay, they should be considered at risk until a proper nutrition assessment shows that they are well nourished and that they are unlikely to become malnourished during their stay. There are two good reasons for this approach. Firstly, a lot of hip fracture patients are already malnourished on admission, and so guidelines recommend starting nutrition treatments from admission for all hip fracture patients. Secondly, most screening tools do not perform well in hip fracture settings. For people with other types of fragility fractures, it is important to make sure that anyone who is screened as at risk of malnutrition using a validated screening tool is offered the results of their screen. Because no screening tool is perfect, we also recommend using clinical judgment. Remember, a person can still have malnutrition even if they are not underweight, including people living with obesity. Finally, anyone who is assessed and diagnosed as malnourished should be offered information about their diagnosis. And again, this diagnosis should come from a validated tool, for example, GLIM, the Mini Nutritional Assessment short form, or the Subjective Global Assessment, not just BMI or blood tests. We know that awareness matters because when patients and carers understand, they are more likely to be part of the solution. If you want to make things simpler, when we look at how we measure awareness of malnutrition or nutrition risk, there are a few easy ways. First, you can review 10 patient charts. Don't do too many, unless of course you're doing a research study. Just check the chart to see if there is any documented evidence of a discussion with the patient or their carer. You can also ask 10 patients who have a good memory. Ask them if they were provided with the results of their nutrition assessment. Alternatively, or as well, you could do a quick survey with staff during your next team meeting. Ask them what proportion of hip fracture patients who are malnourished or at risk of malnutrition and have a good memory are aware of this. It's pretty easy to find out whether it is a major problem or not. And really, you should be able to find this out in around an hour at the most. Maybe 2 hours if you want to look at data from both a patient and a clinician perspective. We'll now look at an example, the story of Mrs. D. Even if you have already seen Mrs. D's case in another unit, you might still want to watch it again to think about opportunities for improvement regarding awareness of nutrition risk. As you watch, think about what could have been done differently and how Mrs. D's experience could have been improved. So why is awareness of nutrition risk status a Simpler Six priority? Firstly, we know that most people with hip fractures and other fragility fractures who are at risk of malnutrition or are already malnourished do not know this. Also, if people don't know they have a problem, they won't take action. Patients won't ask questions, staff won't intervene, systems won't be improved, and so nothing changes. Raising awareness of nutrition risk status is a key Simpler Six action for better nutrition and better outcomes. Let's talk about why awareness of nutrition risk status is so important, especially for our patients. As we saw in the case study, not eating and drinking after a hip fracture doesn't just make people tired or upset. It can lead to serious problems like malnutrition and dehydration, and as a result, many other health issues. In a kind and sensitive way, it is important to let people know if they are at risk of malnutrition or are already malnourished. It is also important to make sure that they understand the consequences of malnutrition. Otherwise, people are not able to make informed decisions about their treatment choices. From a patient's point of view, here's what can happen from malnutrition or nutrition risk. Wounds heal more slowly. There's a higher chance of infections or skin damage. Muscles get weaker, which increases the risk of falling. Older people may become confused or develop delirium. People often stay longer in hospital, and some may need to come back again. Fewer people go home. More people are sent to aged care. Life becomes harder with a lower quality of life and a higher risk of dying. It also increases costs, not just for the hospital and the health system, but also for patients and their families. So when malnutrition risk is not recognised or shared with patients and carers, treatment often isn't started or isn't taken seriously. And that just doesn't affect the patient. It affects the whole team and the wider health system. Without awareness, patients may refuse nutrition care or not fully understand why it matters. Nutrition support may be delayed, forgotten, or seen as less urgent by staff. This isn't just a dietitian's job. Every team member plays a role. Nurses, doctors, allied health, food services, admin staff, and leaders all contribute to how and when nutrition risk is identified, communicated, and acted on. When awareness is low, it's harder to meet care goals like early mobilisation or timely discharge. Staff face more complications, more workload, and more frustration. Patients stay longer, recover slower, and are more likely to be readmitted. Long-term care and aged care needs increase, and so do costs. Our performance on audits and benchmarks may look worse than it should. So recognising and communicating nutrition risk is not just a tick-box task. It's a shared responsibility and a step to better nutrition and better outcomes for patients and for all of us. It's now time to reflect. Why do you think it is, or isn't, important for all hip fracture patients to be offered information about their nutrition risk status? Think about things that matter to patients, communities or populations, healthcare workers, or funders and policymakers. Just put down a few of your thoughts. This isn't assessed, it's simply to get you thinking. Once this video stops, just click on the link to the reflection activity.